All right, hello everybody, and welcome back to the third installment of our Motor Learning Monday mini-series that I'm doing in celebration of Pride Month here in the United States. And what I thought we would do this week is transition from talking about augmented feedback, which is what we discussed in the second installment, and now start to talk about practice conditions and how we can structure our practice conditions to really help facilitate long-term motor learning, not just immediate motor performance. When we think about how we can structure the therapy for a patient, we can think about how we're structuring the specific task or skill that we're trying to train. And then separately, we can think about how we're organizing the practice session as a whole. And so I'm going to touch on each of those over the next few minutes right now. So let's first think about how we can structure the skill itself and how the patient is practicing a skill. When a patient is practicing a skill, we can consider, are we helping them to think about a constant practice condition, or are we going to encourage more of a variable practice condition? So constant practice refers to practicing a target skill with the same movement and or the same kind of contextual characteristics. Variable practice, on the other hand, refers to practicing a skill with a variety of movement or a variety of contextual characteristics. Notably, negative practice is a form of variable practice, which involves intentionally practicing the task kind of incorrectly. So what are some examples of this? Well, if we think about maybe voice therapy, we could have a patient constantly practice the target skill. So that might be to do a smooth and efficient voice, so a voice that has a medium amount of airflow with very minimal muscle tension or strain. So E, 1, 2, 3, 4, 5. If the patient practiced that the entire therapy session, then we would be encouraging and facilitating a constant practice condition. Alternatively, we could have the patient perform a variable practice kind of version of this therapy. That might mean that if a patient is kind of undergoing, let's say, 10 sets of practicing for this voice therapy, maybe 7 of the sets is that target voice, where 3 or 4 of those sets might be doing some negative practice. So maybe instead of having them do that smooth and efficient voice with kind of moderate airflow and very little tension, we might have them practice with a more of a strained voice that is smooth but strained and very little airflow but also lots of tension. Or we might have them practice with more of a rough and strained voice so they can kind of hear that difference before moving back to that smooth and efficient voice. So it's practicing kind of the right way on purpose and then separately kind of the wrong way on purpose. If we bring this to kind of the dysphagia realm, maybe we're having a patient practice doing some cough skill training to really encourage strong and effective coughs to eject that aspirate material out of the lungs when they aspirate. So if we did a constant practice condition, we may be always having the patient practice a strong and crisp cough, something like that. That's what we want them to ultimately learn. That's our target kind of learning goal. However, we may have the patient do a variable practice kind of structure or condition, whereby maybe they're doing 10 sets of cough skill training, and maybe 6 of those sets is that strong and crisp cough, and maybe 4 of those sets is maybe a weak and crisp cough, or maybe it's strong and not crisp with lots of voicing. So in a lot of the patients that we see, those are actually the coughs that they're doing. So we may have them do it the wrong way on purpose and then the right way on purpose. They're kind of going back and forth with it geared more towards that kind of target learning goal. So that would be the difference between a variable practice condition as opposed to a constant practice condition for both voice and kind of swallowing therapy. If we kind of think of some more traditional swallowing therapies, we might be thinking about something like the effortful swallow technique, right? So this is a task where if we use it from a skill training approach, like if we're trying to teach someone to use more effort with their swallowing, then we may have them practice 7 of the sets with that kind of 8 out of 10 effort. That's what we're maybe wanting to train them to consistently and accurately do when they're eating and drinking. But we might intermittently kind of have them practice maybe a 2 out of 10 effort, being kind of as lazy or as soft as possible. So again, they can get a sense of what that feels like versus what that strong and effortful swallow feels like. So that's in terms of thinking about how we can structure the skill itself and what we want them to practice. We can also think about how we're structuring the entire practice session or therapy session. And there's a few different ways that we can do this. We can do blocked practice, randomized practice, and quasi-randomized practice or serial practice. So blocked practice would be practicing just one skill at a time, doing all of our sets of maybe our voice therapy, completing all of those sets before moving on to maybe cough skill training, and then doing all the cough skill training sets, and then maybe going on to swallowing therapy for doing that, right? So block practice is doing all of one before moving on to any other skill, whether it's within the same session or in a different session. Randomized practice would be randomly selecting sets and doing that over the course of the entire session. So let's say we have 10 sets of voice therapy, 10 sets of coughing therapy, and 10 sets of swallowing therapy. We're going to randomly select out of these 30 total sets what's coming next. So you might kind of draw this out of a hat. You might use something like Excel to kind of randomize the sets. So we might randomly have 3 voice therapy sets followed by a cough set, a swallow set, a cough set, another 3 voice therapy sets, then 5 cough sets, and then 5 swallow sets. It's very random and can be a lot to handle. So that kind of brings us to the last structure, which is kind of quasi-randomized practice or serial practice. So there we might kind of structure the therapy so that it's not blocked and we're kind of interspersing the skills, but doing it in a little bit more of a structured way. So we might do maybe 4 voice therapy sets, followed by 4 cough sets, followed by 4 swallowing sets, followed by another 4 voice sets, another 4 cough sets, another 4 swallowing sets, and then 2 voice, 2 cough, and 2 swallowing, something like that. So we're kind of doing a kind of cyclical round of our 2 or 3 different skills that we're practicing within our therapy session. So you might now be asking, well, what's the best thing for motor learning? And the reality is that it probably differs from patient to patient. And a lot of this motor learning literature, again, has been done in neurologically healthy adults. So if we're working with people with, brain diseases or disorders of the brain, it might not 100% translate. So that's important to kind of keep in mind. However, we can still pull from this very large body of literature. And the thought is that having some amount of what we call contextual interference is probably very good for motor learning, long-term learning, maybe less good for immediate performance, but better for motor learning, which is what we care about as therapists and speech pathologists. So what is contextual interference? Contextual interference is the memory and performance disruption, or the disruption from memory and performance, that results from performing multiple skills or variations of a skill within the context of practice. So again, contextual interference might immediately kind of impact motor performance such that we have kind of greater error or less accurate motor performance, but across a large body of literature tends to demonstrate better long-term motor learning outcomes, which again is what we care about. It's a little unclear why. There's lots of different hypotheses. So if we are having someone practice voice and they're kind of getting in the zone, and then we're telling them to do their voice the wrong way on purpose, and then go back to that right way on purpose, there's a couple different things that's probably going on there, right? The person is probably starting to process, okay, what did I have to do to make it wrong? And then now what do I have to do to make it right? So there's lots of error processing going on. They're probably also starting to develop a sense of discrimination skills, to be able to hear a difference and to be able to see a difference. And as a result of that, likely are starting to become a little bit more independent. So we're kind of getting them out of the zone. They're having to error process. they're increasing likely their discrimination skills and their kinesthetic awareness. And actually, and this is probably something we'll talk about in our last motor learning Monday, is this sense of autonomy and enhanced expectations. So they're likely going to be able to do the wrong way on purpose really well if we're throwing negative practice in there. And so they're going to kind of feel like they're going to be able to kind of master a skill. And by just getting this sense of enhanced expectations and feeling like you're going to be able to do it well, people start to actually do things a little bit better. So there's probably kind of three mechanisms for why contextual interference is important for motor learning. And in fact, this is seen so much in the literature that this actually has a name, and it's called the contextual interference effect, whereby learners tend to demonstrate greater benefit when practicing under high contextual interference practice conditions as opposed to low contextual interference practice conditions. So what has higher contextual interference? Very well practice has more contextual interference than constant practice. Why? Because we're disrupting the variation of the skill. Rather than having them practice the same skill over and over and over and over again, we're having them do it the wrong way on purpose and then practicing the right way on purpose. So we're disrupting them being in the zone. Randomized practice has the most contextual interference when compared to blocked practice, but probably a little too much contextual interference, and that's where serial practice or quasi-randomized practice comes in. And so something that we're thinking about as clinicians is trying to find that balance of having some amount of contextual interference, but we don't want to make it so highly interferency that the patient is getting frustrated and not having the sense of autonomy and enhanced expectations and is kind of getting frustrated about the situation. So we're trying to kind of find that middle ground. And I think the important thing for you as a clinician to keep in mind is that we should be integrating some amount of contextual interference in our therapy sessions. That is not a bad thing. That's actually a good thing. We want to disrupt them. We want to disrupt the system, perturb the system, and have them figure out, have them troubleshoot to get back to that good spot that they were probably in. So we want to kind of break them up. The moment we see them in the zone, let them be in there for a little bit, but then break it up, have them do another skill altogether or the same skill but in a bad way, and then kind of have them figure out how to get back to getting back to being in the zone. All right. I hope you all enjoyed this. This is actually one of my favorite concepts of motor learning. I integrate this all the time in therapy sessions. I hope you learned a lot. Hopefully you'll explore this too and begin to integrate this into your voice and song therapy sessions as well. All right, everybody, take care. Bye-bye.